Petra, I think you're on mute.
Okay. Would help. I was saying it's 7 o'clock. Shall we get started? Do you want to start, Joy?
Sure. So good morning, good afternoon, good evening, everybody. Thank you for joining this knowledge and learning seminar on resource mapping. Sorry, I just had a resource mapping and expenditure tracking during the COVID-19 outbreak. I will start with a bit of housekeeping so that you can navigate the system. I'll share my screen so that you can see what I'm pointing to. So first, to select the language and have access to interpretation, please go to the left-hand side of your screen under Dr. Yeko here, where it is written floor, and you can select English or French. I'll say it in French as well. Pour les francophones, pour sélectionner la langue, l'interprétation dont vous avez besoin, à la langue dont vous avez besoin, vous pouvez aller à gauche, en bas à gauche de votre écran, là où c'est marqué floor, F-L-O-O-R, et choisir le français. Switching to English, the default troubleshooting method on Kudo on this platform is to refresh your screen. To do that, you can go onto the circular arrow here on the top left of your browser, or you can just click on the address and click enter. During this webinar, we will have a session dedicated to questions. For those questions, please send them via email to either Petra for English speakers and to me, Joy Gebermeden, for French speakers. The reason we ask you to send your questions and comments exclusively via email is that it's very difficult to follow the messaging board that is here on the right-hand side next to Dr. Ludi's video. The messaging system will, however, be helpful for you to get technical assistance from the operator. My system is in French, so opérateur. And also to send private messages to me, Joy Gebermeden, for French speakers. I'll be able to help you with any technical issue that you're experiencing as much as I can. On the bottom left, after messaging, you see there is documents here. All the presentations are available here, and you can download them with the agenda by clicking on this downward looking arrow. Only the English version will be projected. Kudo only allows for one version to be projected at the time. So please, for the French speakers, go to documents and download the presentation for ease of viewing. I think that's about it for me. Back to Petra.
Thank you, Joy. And for those of you who are not familiar with this system, Kudos is one of the few systems that allows for simultaneous translation, which is why we're using this system so that both French speakers and English speakers can connect together and we can have an exchange of lessons and questions among each other rather than just one language. So my name is Petra Vergeer. I'm the GFF lead for knowledge and learning and results-based financing, and I'm very happy you are all here. We have many countries connected. I already saw a large number of participants. We will have participants from Afghanistan, Bangladesh, Burkina Faso, Cambodia, Cameroon, Central African Republic, Côte d'Ivoire, Democratic Republic of Congo, Indonesia, Kenya, Madagascar, Malawi, Mozambique, Myanmar, Nigeria, Rwanda, Senegal, Sierra Leone, and Uganda. And I'm truly sorry that we can't meet all of you in person, but I'm really, really happy that so many of you have connected for this very important session that I think is really critical at this time to talk about resource mapping and expenditure tracking in the context of COVID-19. This is a topic that many of us are interested in, and I think it's really an important session to look at how both the current emergency response and the longer term vision all comes together. So I'm very happy that we have a very esteemed panel of guests here with us to speak about this topic. So we will start with Marion Crow, who is a senior health economist in the GFF Secretariat. And many of particularly the French-speaking countries will know Marion because she's been supporting on the resource mapping side. And then later on, we will also see Vibhuti Hate, who is a health economist at the GFF Secretariat. And she has been supporting a lot of the English-speaking countries. And then I'm very happy that today we're also joined by Dr. Ludis Suryantoro, who's the head of WHO Multisectoral Engagement for Health Security Units, and Sean Cockerham, who's is also with the WHO Multisectoral Engagement for Health Security Units, who are also very much working on this effort. And then I'm very pleased that Dr. Yeko Belete, who is the Director General for Health Systems and Operations and the Task Force Lead for COVID Response Resource Mobilization in Ethiopia with the Federal Ministry of Health, is also able to join to share some of the experiences. Thank you, good to see you. We already heard from you during the last webinar on supply chain, and I'm really happy that you're here to be willing to share your experiences. And I know later on we'll also probably hear from Dr. Feven Girma and Dr. Zaki during the question and answer session. So I'll introduce them during that time. So with this, why don't I ask that we get started, because I know we're all keen to have discussion and question and answer, because that's always the most important aspect of this. So Marion, I will hand it over to you. So, and just for those, if you're French speaking, please look in the documents file for the slides, but I think we're starting possibly in French, is that right?
Oui, merci Petra. Oui, donc en effet, je vais commencer.
Yes, thank you, Petra, and I will begin with the presentation and a number of elements in the RMET in the context of COVID-19 in French, and my colleague from Djibouti will continue in English before I give the floor to the different panelists. Next slide, please. Thank you. Thank you. Now, before we get into the nitty-gritty and delve into the topic, this webinar was conceptualized about 2-3 weeks ago, at the time when several countries of the GFF were turning to us to ask us whether we could support them in resource mapping and expense tracking for a COVID-19 response. And we thought it would be good to have a webinar to share the experiences of the countries with respect to resource mapping, the resource mapping in terms of the COVID-19 response. And as part and parcel of the experience we've had as to using a specific tool, a resource mapping tool with respect to COVID-19 response. And I hope the discussion will be focused more on the utilization of data. This is something very important for decision makers and politicians, leaders, in order for them to monitor very closely different aspects of this pandemic. Now, in order for us to be all on the same page, on the same wavelength, we're talking about RMET, resource mapping and expense tracking. When we talk about RMET, we're talking about the budgetary commitments made by donors in the sector of public health and the monitoring of such funds. And so in the same context, we're trying to see the same sort of movements in terms of the priorities of the investment framework, the priorities of the national public health strategy, and we compare things in order to see whether we have really big gaps in terms of funding. This information is very useful in order to prioritize more. If you need a 4% extra investment in some area, then we have to focus on that. And this is also in order to better monitor resource allocations and investments made within the framework of the public health strategy. When we talk about national health accounts, we're talking about the efforts deployed by the Ministry of Health with the support of colleagues of the World Health Organization. And within the framework of GFF, it is more of a tracking of expenses and of the priorities within the investment framework. We're talking about collecting, comparing budgetary data, expenditures, expenses in the investment framework to see whether these investments and these plans are appropriately executed and that disbursements are done according to these various priorities and preconditions. Next slide. And now I'm going to give the floor to Djibouti, English.
Marion, je vais juste amener Djibouti sur le floor, comme ça.
OK.
Sorry, I'm just going to get Djibouti to come to the floor. Thank you.
Hello, everyone can hear me?
We can hear you.
Perfect. I need to share my screen, Joy. Thank you. All right, thank you, Marion. We now move on to why we conduct RMET during a COVID response. So there are two aspects of responding to an outbreak. First, of course, is the direct response to the outbreak, which requires mobilization of additional resources. There's also the coordination of partner response that is required. And then the resources that have been mobilized need to be deployed to the front line. These are just examples. There are other aspects to responding to the outbreak as well. But these are the areas and the dimensions that are related to resource mapping and expenditure tracking. The next aspect, the second dimension, is mitigating the impact on the health system that provides routine service delivery. So we want to make sure that we reduce the impact that this has on delivering routine services. We want to also make sure that the long-term funding for the health sector is not undermined by the financing that we provide for the outbreak, which of course is very critical, but in the long term, it shouldn't lead to a reduction in resources for the health sector. And then lastly, we want to make sure that the pandemic response is aligned with long-term health system strengthening. So for instance, if lab capacity is really strengthened in the country as part of responding to an outbreak, we want to make sure that those gains in improving lab capacity are sustained. So where Armet aligns with these dimensions is as follows. The additional resources that have been mobilized, this is great. But of course, what we really want to be able to also look at is the financial gap. So what is the cost of responding to the outbreak, which we get from the costing? And then these resources that are mobilized, is that sufficient or is there a gap? We want to ensure that the response by partners is leading to the allocation of resources in a way that is not duplicative. So, and everybody's not doing the same thing in the same part of the country, whereas there are gaps in other parts of the country. Armet allows us to look at this. And then lastly, for the first dimension, Armet also allows us to be able to monitor the resources that have been deployed. So this is the budget that was set aside for the response. This is how much has actually been disbursed. This is what has been spent. And has it been spent in line with where the resources were intended to be sent? When we look at the second dimension on reducing the impact on the health system in terms of routine service delivery, Armet allows us to look at if the emergency response is having an impact on essential health services, because we're tracking where resources are being budgeted and where they're being spent. We can also take a look at the financing of the outbreak and how that's impacting the health sector budget. This is with the resource mapping, which is related to budgets, as Marion discussed, and then also the expenditure tracking. Where is money actually getting spent? And then we also want to make sure that the activities that have been prioritized for the pandemic response aligns with the health system strengthening priorities in the national health plan, so that we can make sure that those gains are sustained. So we're looking at 3 use cases, which are 3 examples of how the resource mapping results can be used. The first is where the resource mapping and expenditure tracking can tell you about the funding gap for each pillar of the COVID response. So if we look at, for instance, medical equipment, logistics, and supplies, the green bar is the domestic resources coming from government, blue is the external resources coming from donors, and then the gray bars are the gap. And we can see that there's a huge gap for medical equipment. There's also a big gap for laboratory. Even more importantly, we can see that whereas for medical equipment, you get funding from donors and government, for laboratory, strengthening, it's mostly donor financing because there's only blue, and the gap is substantial. We can also tell from the resource mapping that for coordination and surveillance, there's more funding than is required. So this is also important to know. Of course, we want to know where the gap is, but we also want to know where there's more funding than is needed. The second example, the second use case is where we're tracking budget execution. So keep in mind that this has been done very early on in the response. So if we look at, say, the example for medical equipment, logistics, and supplies. So this is just a section of the previous graph. So the line in blue, that's the budget, the total budget that has been assigned. This is domestic and external financing has been lumped together for the purpose of this graph. So the budget is approximately 210 million. The green bar is the disbursement. So 80 million has been disbursed. Expenditure is about 40 million. And the red dot is the budget execution rate, which is at approximately 45%. Now, if we just look at the expenditure of 40 million, it's very easy to say, oh, health spending is not even half of what the budget is, the budget that has been allocated. But what is important to keep in mind is that, yes, you may have disbursement challenges because even disbursement is only at 80 million, right? So that's less than half of the total budget of 210. But for this country example, the important thing to keep in mind is that this was very early in the pandemic response. But if you see the same sort of graph, let's say 6 months into a pandemic response, then clearly disbursement is an issue because 6 months into the response, we shouldn't be disbursing less than half of what has been allocated. If this is a graph that you're seeing 1 month into a pandemic response, that makes sense. Disbursement has not actually got underway. Another issue to think about is issues with getting funding. Because if you notice, disbursement is 80 million, but again, expenditure is 40. So it's only half of disbursement. Again, this is a graph that was 1 month into the response. So probably the expenditures just haven't caught up with the disbursement. But if you're looking at this 6 months into a pandemic response, some of the things you can consider are, is there absorption capacity issue that we're trying to put money into the field, but the facilities are not able to absorb the funding? Or is it that there's a problem with procurement, where procurement rules are such that it's hard to actually purchase equipment, even if you have the funding available? Or possibly there are other health systems issues that we need to think about, like supply chains or insufficient supply of ventilators, which has nothing to do with budget or disbursement. But if there aren't sufficient ventilators, for example, to be purchased, then expenditure is going to be low. So these are the kind of things that the second use case tells us. The last example is where we're looking at the allocation of the budget compared to the caseload. Now, this is from Ghana, and this was very early in the response. So that's why on the right side, you see it says budget commitment per capita. We did not look at expenditure because we didn't think that would give us a very good picture because the response had just started. On the left side, you have the cases per 100,000. On the right side, the y-axis, you have budget commitment per capita. And then, of course, on the x-axis are the different subnational levels within Ghana. So what this shows us is the yellow, the brown bar, that's the COVID cases per capita, and the red is the budget commitment per capita. And you can see that for the most part, the red dots are in the same at the same level as the brown bar, meaning that the budget commitment per capita is on the same path as the caseload that we're seeing. An important thing to notice here is that in some places like the Western area, you'll see that there is a red dot, but there is no brown bar. That's okay, because we also want to put money into prevention and preparing for when when COVID will reach these parts of the country. So nowhere should you see a completely empty spot that there's no budget commitment. So here, for instance, in these last 4 regions, we see that there's no cases, but there is money being assigned to these areas, which is what we want to see. And I'm going to pass it on to Marion for the rest of the presentation. Thank you.
Merci, Vibhuti.
Thank you, Djibouti. Joy, can you put the slides back on? Thank you. One moment, thank you. Sorry about this. One moment. Right after this one. Right. Yeah, thank you. So the message we have in these slides here, what we want to try to find out is what we should do to carry out a mapping for a resource mapping process for the situation of response to COVID-19. So there has been the WHO tool and the GFF tool, which we had developed for resource mapping and the investment cases, so which we had developed for the mapping of resources for COVID-19 response. And I believe that you've all developed your own resource RMET tools. So over and beyond Djibouti, it is important to say, and I think that is what Djibouti has already presented, what is required and what is this information going to be used for? And this is where the use cases come into play. And it is important to find out what the volume we want in terms of data collected for responses to COVID-19 relative to a given objective. First and foremost, perhaps, it will be resource mobilization. So if indeed the objective is resource mobilization, what should one do? It means you need to gather budgetary information of donors and the government itself vis-a-vis the priorities and pillars of the COVID response system, which has been costed, in order to see where the gaps are, where the differentials in funding are, vis-a-vis certain priorities and for certain specific regions. When you have the objective in mind clearly, it will make it possible for you to decide what kind of information, here, budgetary information, as well as the costs. And now, if your objective is different, if your objective is more of a monitoring of the implementation of the national COVID-19 plan. In that context, not only budgetary information of the donors and the government vis-a-vis the pillars of the COVID-19 response, but responses and disbursement information to find out whether each actor, whether we're talking about a donor or the government itself, fulfills indeed their commitments vis-a-vis the objective set out. So I wanted to come back to that notion of utilization of data for political or for decision makers. Next slide. And this is the last slide in the introduction. How can GFF support RMET for COVID response in 36 countries in the mapping of resources in COVID-19? For reacting to COVID-19. So we have a checklist, as it were, that provides a number of examples of the type of analysis that may be very useful for decision makers to carry out in using data and resource mapping for responding to COVID-19 that we could develop, that can be developed as of next week. These are tools that are developed between Gates, World Health Organization, GFF, and we can provide you support and put you in touch with the Djibouti team that has developed a mapping tool of the COVID response. And we also have available a GFF tool that can be useful for you to carry out a mapping of the response to COVID. That's more the short term. On the medium and long term, I think it's very important to evaluate the impact of these emergency responses, especially with respect to essential health services. Whether we're talking about the framework of your COVID mapping framework or your investment framework, it is important to collect information in order to be able to evaluate whether there has not been enough prioritization of essential services to provide. In gathering the resources necessary to respond to COVID, is this being done to the detriment of other services? It's this type of information that is very useful to see what the impact of COVID is on essential health services, and to make sure that these are also protected in the long term, to link these two processes, whether we're talking about COVID mapping with your national health strategy, in order to make sure that these are not silos and vertical processes that are completely separate. Now I'd like to give the floor to my colleague. Thank you. Marion? Thank you. We are very happy to be here and participate in this webinar. And we have some slides that we have prepared for you regarding the health security resource mapping. Do you want me to present in French or in English? I wasn't quite sure. Marion? In English would be fine.
First slides, please. Thank you. So before we're going to start into a deep dive conversation about our resource mapping tool, I would like to just very briefly to get where we are coming from, what mandate, and where we are heading. So our team is responsible for the acceleration of the implementation of IHR. Our particular mandate is basically the Article 44, of which this is legally binding between 196 countries, about mobilization and financial resources to support developing countries, as well as provide facilitate the technical cooperation. So our objective is to accelerate the implementation, also to share information, but it's also mobilization of resources to support country implementation. Our hope is to build the country ownership through WHO leadership, but is working in partnership. We have only three products that we are delivering as a unit. Is basically, first is what we're going to present it to you, the resource mapping. The second is about multi-sectoral, engagement that in health security, we are, we engage with so many different sectors, non-traditional, including military and private sectors. And that is the nature of the health security preparedness. The last part is basically the financing. We are in the process of developing the compendium of funding options. And this is based on what you call it, the International Health Regulations annual reporting, the joint external evaluations process, and the NAPs. And of course, leading this, we are linking with the UHC process as well as SDGs. Next slide. La prochaine, voilà. So in this slide is basically just to provide, I'm not sure it's very clear. It is just to provide you a little bit the situation in Africa in terms of COVID. So as you know that our resource mapping platform is also linked with the COVID-19 platform. As you know that WHO is launching the COVID-19 platform where all 60 country plans, all the country plans is stored at that platform. So this is just to give you about the situation in Africa. After this slide, I would like to ask Sean. Sean will provide you a very deep dive experience about how we are using the resource mapping tool, and also provide you with a little bit explanation on the features. Sean. Was that mute, Sean?
We can't hear you, Sean.
Sean, I think, oh yeah, Sean is still online. Sean, can you hear us?
Sean? I'm not sure what happened with Sean, but it seems that Sean, can you hear us?
His microphone seems to be on, but we cannot hear him.
Okay, this is Petra. Can I suggest that otherwise we listen to Dr. Yeko first and come back to Sean? Maybe he can refresh his page and restart. Unless you want to present on his behalf, Dr. Rudy?
Well, I can try to do that, although ideally that Sean will, will present this because, he's actually doing the implementation in the field. So I mean, it's up to you. Do you want me to proceed with this?
We can also first ask Dr. Yeko to present on Ethiopia and come back to Sean after that. Hopefully by then this issue is resolved.
Yeah, klar.
Yeah, shall we do that?
Yeah.
Dr. Yeko, are you okay with that?
Yes, I'm okay with that.
Thank you very much. So then I'll just ask everybody to please, for the French speakers, to download the presentation on Ethiopia that's in the document folder on your right. And we'll come back to listen to Sean about more of the experience and the work done by WHO on this. Dr. Yeko, over to you.
Thank you so much. Hi, everyone. I'm going to present the experience from the Ethiopian COVID-related response, mobilization, and allocation. Next slide, please. These are the contents. I will give very brief introduction about the pandemic in Ethiopia and with a little bit of a background on Ethiopian emergency preparedness and response. And I will dive into the resource mobilization and allocation tasks and a tool with summary takeaway messages. Next slide, please. So everybody knows this is COVID, and almost more than nearly 3 million people confirmed, and the days have passed 200,000. So we can see, Africa is not spared from all this, and in Ethiopia, we'll see it in the next slide. This is another tool that we are using, the WHO Afro region. This is outdated data, but we are using it, our technical advisory group at a ministerial level in our Ministry of Health office. We'll use such issues and then update it and then share it for everyone on a daily basis. Next one. So this slide is very critical for Ethiopia. We started the first case sometime in February, but before February, when it was announced that the disease is pandemic, we have started our scenario plan, which is preparation. This is very important, planning based on scenarios for resource mobilization. So in February, we have started, still no case, but we have taking test samples. We have been transporting it to South Africa, and our rapid response team has been, deployed. We have it at federal level and at subnational level as well. And sometime in April, we have seen cases increased from the baseline, and all our teams have been activated and active quarantining all comers from abroad, as well as isolation centers and treatment centers get ready. And in March, before April, we have announced our scenario 2 because it has passed from preparedness to response. And then in April, as I have told you, the cases have increased more than 100,000. So in May, the worst case scenario, possibly, we will see cases in 3 months greater than 90,000, which breaks down to 30,000 cases per month. So we are expecting this, and all our resources which we are going to mobilize are based on these scenarios, and it's very crucial for all our African countries to really focus on scenario-based planning. Next slide, please. So this is another database which we have in our Ethiopian Public Health Institute, where we follow cases where cases are there in zone at Woreda. These are like district and then sub-district level mapping tool, and how many have been affected, how many regions, and how many have still not seen the case, but that they have started the preparation. Next slide, please. So this is again now zooming into the epicenter. Addis Ababa, which is the capital of Ethiopia, is the epicenter of the COVID outbreak. Nearly 90% of cases are within Addis Ababa. So we can zoom down and see which sub-city within Addis Ababa have cases, and then all these. Definitely, Addis Ababa is like a province or a region. We call it a region, and in other countries we call it a province. So when we allocate resources, even before allocation, when we plan resources, this is very crucial, and all inputs are related to the case distribution. So these mappings are really, really important to define our scenario and also to use it for resource mapping as well as allocation. Next slide. So this is another dashboard which we are using on a daily basis. So this is a daily monitor, and it has the online surveillance dashboard, which anybody can go into the website and really see the scenario. So these are all information where all stakeholders, including government stakeholders, non-governmental ones, and all over the world, donors all over the world would like to see. And based on this, our plan, our resource mobilization, and our mapping will also follow this information. Next slide, please. So having said that, where did we start? We activate our national, emergency center as soon as we heard there is a pandemic. So we divided our readiness into two. Sectoral readiness, which is through the Ministry of Health. We activated the National Public Health Emergency Operating Center and all advisory structures. They have been there before COVID, so when we hear such, we will activate that. The second readiness is at a multi-sectoral level because, epidemics or pandemics like COVID, they need a multi-sectoral response. So we need to also alert the multi-sectoral readiness, which is currently led by our head of state, which is the Prime Minister of Ethiopia. So once we activate that, then the preparation for emergency and then response planning has continued. As I mentioned before, so scenarios were outlined by the scientific team, and then the budgeting and the planning followed which scenario to follow in. Next slide, please. So this is the overall, organogram of
Dr. Yeko, I apologize for interrupting you. I realized that I didn't project the right PowerPoint and the dashboard is on another one. So if you just give me a second, and I apologize for the interruption.
No problem, Joy. So I can talk while you are projecting the slide. So, but so far, it is very correct. So maybe the subsequent slides, it's good that you are going to change it. So at the national level, the coordination structure looks under the Ethiopian Public Health Institute. There is a specific emergency operating center who are doing the nitty-gritty, preparedness as well as response planning. But at the federal level, at ministerial level, we have a support structure for the emergency response center. So resource mobilization and private sector engagement is one of the advisory, task forces, which is based at the headquarters, the Ministry of Health headquarters, providing, advices and resource mobilization and approach to different international and local donors using the plan on behalf of the Emergency Operating Center. Next slide, please. So now zooming it down to the Resource Mobilization Task Force, which is based at ministerial level, we have team members, about 9 of us, and all of them are health financing experts in resource mobilization case team under our partnership and coordination directorate. We have also partners such as WHO and then the private consulting firm called Dalberg. Once we established our team members, we developed our TOR, and basically new resource mobilization, following up resources in the pipeline, as well as resource allocation is the 3 major functions for the Resource Mobilization Task Force. And we have a coordination meeting twice daily, check-in and check-out meeting, so that we see the progress on a daily basis and communicate to the major task force or command post. And task force members individually, they report on a daily basis. And we have a monitoring mechanism, which is in a form of database, which converts into dashboard. And a weekly report is expected from this task force to the National Coordinating Committee. Next slide, please. So, factors we considered during this resource mobilization, I will quickly go through them. So when we say resource, it includes financial resource, in kind, such as material, equipment, infrastructure resource, and human resource, as well as technology. So when we say resource mobilization, we mean all these mobilized, and each one will go to its specific area. For example, the technology one will go to the technology task force for COVID response. The human resource, as soon as we get the human resource, volunteers with different expertise, we send them to the human resource coordinating task force. We only follow financial and in-kind resources given to the Ministry of Health for the national response. So sources of the resource, this is also very important. Internally available resource. After the COVID first case has been reported, we have, literally mainly shift to COVID response most of our activities, such as like we can't conduct trainings, we can't conduct meetings, we can't just travel all over the country for supportive supervision. So we have identified this available, funding internally for repurposing. And also this is a very good opportunity for us to negotiate with central government to allocate a lot of money for COVID response, and any investment during COVID response is an investment for the future. So this is what we have done, and so far we have almost secured nearly $20 million for COVID response from our government, and also a resource from other government, non-health governmental sectors, Ministry of Transport, Ministry of National Disaster Risk Management, Commission, all these, they have some resources where we can easily utilize or integrate for the response purpose. Non-governmental partners are our key partners. So for repurposing of the existing funding, as well as new grants and loans, is also a source of resource that we have used. Private sector, this is a time more than ever we have seen the actual impact of private sector in our response, not only by providing us many, like such as banks and manufacturing, industries, they give, monetary resources, but also they showed us their capacity to have local, production, fast and efficient importing system, for COVID inputs, service providers, which are highly, technology oriented and then also high expertise, as well as new entrepreneurs to come up with solutions from the information technology up to producing new entrepreneur-oriented, personal protective equipment, and also civic society, the Health Professional Association, as well as the Ethiopian diaspora. These are the sources for our resources, and the levels, international level, national, and at sub-national level, this resource mobilization and allocation has been used. Next slide, please. Another factor that we have considered in resource mobilization in private sector, engagement is our approach. So we share the scenario-based emergency preparedness and response plan for international, national, and regional donors. Specific proposals based on request out of the national emergency response plan has been developed, such as for World Bank, for Gavi, for African Development Bank, all this. And we do follow-up calls, emails, and meetings, as well as regular engagements. It used to be once per week with all partners and donors, but now we have changed it into twice a month for monitoring the status, sharing priorities, as well as what has been mobilized, what has been allocated. So these were factors we have considered. Next slide, please. So for resource allocation, our recipients for the resource are federal level institutions, such as Ethiopian Public Health Institute, our research institute, which is another testing site, federal hospitals reporting to Ministry of Health, as well as professional associations which are working with Ministry of Health, and regional health bureaus. Regional means provincial health offices. They are the actual implementers, including Addis Ababa, so they are the recipients. Civic societies and local NGOs, which we have selected in the response, are the recipient of the resource. And resource allocation approach includes, there is a federation allocation formula, which is population-based, and other socioeconomic factors also included. There is a formula for this, works for regional health bureaus or provincial health offices. For institutional and regional gap analysis is another very important tool that we have used. So all provinces, when I say region, it's like in other countries, a province, all regions, they did emergency response plan, and they also did a gap analysis. We are in the process of finalizing their gap analysis, but we have been using for the earlier gap analysis that they have used. And specific proposals by civic society and local NGOs is also another approach for resource allocation. And we will refill resource based on efficient resource utilization report, and also based on additional new special contexts, such as returnees from Middle East. We are now receiving a lot of returnees, and also internally displaced people because of environmental bad conditions, so droughts, so there are internally displaced populations. So for those regions and locations, we allocate special consideration resource with special consideration. Next slide, please. So the monitoring part is also very critical in resource mobilization. So we developed a database and a dashboard, which I will go through one by one at the end. And also we report using these platforms on a weekly basis, for our task force, for a bi-monthly phases, for donors and partners, and also on a daily basis for overall technical task force members, so that all task forces are really looking into the resource mobilized, resource allocated, and then efficient use of resource based on the dashboard, which I'm going to go through in the next slides. Next, please. So this is a summary dashboard which shows resources mobilized, how much has been committed. So our total amount of money for our worst case scenario response plan is nearly $430 million. This is for the health sector response, but the multi-sectoral response is nearly $1.3 billion for 3 months. So this is our basis. So we share this for every donor, and then when they commit, this summary dashboard shows how much have been committed. So far, $230 million have been committed in kind, in cash from all types of donors. So this dashboard is very visible. And then the total amount of budget by donor, total amount of budget by, the amount committed again by donor in cash, in kind, as well as by funding gap by pillar. Our emergency response plan has 7 pillars. So we have seen which pillar has been funded so much and which pillar has gaps. So this will help us to really see when we get flexible resources, and as well as government resources coming from treasury, we will allocate it based on this pillar-based resource analysis that we have. And we have also top 10 funding agencies. So when we share this on a bi-monthly meeting with donors and partners, they will utilize this to prepare themselves for allocation of new budget, as well as follow the performance of each pillar by end of every month. Next slide, please. So this is a summary one. The next slides, I will go to the detailed database and resource mobilization and allocation dashboard. So as you can see from this slide, the ones on top, the total commitment, the total budget is what we have, the total commitment by partners, and then which ones are already delivered, and which we have received in cash and also in kind. So we have listed 7 pillars, and as you can see, the 7th pillar, evidence generation and operational research pillar, is the least funded, whereas the leadership and coordination is almost funded fully. So this is very useful for us as well as for our partners, where to allocate existing money as well as generate or mobilize new additional money. So we have budgets in 2 types. One, like some donors, they give us earmarked money based on specific proposal, for specific pillar. Some donors, they give us money on a flexibility basis. So this tool will help us. Okay, with the earmarked one, we can't change it, but for the flexible funding, we can use the manual allocation, where this tool will help us where to allocate more money from the flexible source. Next slide, please. So another component of this dashboard is funding by pillar and funding gaps. As I have said, which one has been funded in a good amount, which one has major ones. The 2 ones are surveillance and contact tracing, as well as case management and infection prevention control are the most unfunded pillars. In fact, not only it's not the amount of resource which is less, but these are very expensive, services. So we know that, if we put more on these 2, it will definitely blank the rest, because they are very expensive services if you compare it with other pillar. So they still have gaps, and the more resource we mobilize, the more money we allocate for these pillars, and we'll see it decreasing as we move on. Next slide, please. Another component is resource mobilization, which is done at a regional level. What you can see is that there are about 9 regions and 2 bigger cities with their own plan by pillar. So we are following this, and now when they finish the gap analysis, we will also incorporate the dashboard based on the gap analysis. So this will be factored in for resource allocation. We know that what they have mobilized within their region will be factored in, what the government will allocate, what local donors will repurpose their resource in these regions, and then the remaining gap will be filled by the federal level or the central government level. We can share some of the resources mobilized at a national level. Next one. So another component is donor overview. This dashboard has donor overview. It has, committed and in kind and in cash. For the ones committing in cash, there are earmarked and non-earmarked ones. And as you can see, the earmarked ones are the World Bank, the Global Fund, the Roche, as well as Gavi. They have, earmarked funding, but the rest, Ministry of Finance, MOF is our own treasury, Ministry of Finance. Then Prosperity Party is a governing party, European Union, USAID, they give us non-earmarked flexible funding. This is very helpful for us to use, especially the non-earmarked ones, to manually, allocate for different pillars as well as different institutions. And the one on the right hand is those in kind. So we list them down. It's a very long list, but I just take a snapshot of a few one for our understanding. So this tool is very interactive. It will be shared with government as well as non-governmental partners, and it will help us to allocate more money and also mobilize additional money from the internal as well as from the international sources. Next one, please. So, it's not a rosy road so far. Between the beginning and now, there are challenges and areas of improvement. So resource mapping, there should be an integrated and comprehensive resource mobilization tool. There is already work which has started a few years ago, but it has to be, finalized and used. So when this COVID just popped in, we didn't find this integrated resource mapping tool ready to be used. So it's work in progress, but we will continue working this opportunity and integrate it with the health sector transformation plan one. And there is a late multi-sectoral response initiation, even though the health sector responds fast, including repurposing the existing resource and mobilizing, health and population nutrition donors. But the multi-sectoral response took a little bit of time. And there is also a disbelief on, our scenario-based plan. When we say in the worst case scenario, we will see 31,000 patients per month, people as well as the government couldn't really believe. But when the outbreak takes, part of almost all over the world, then they started to really see. So this can be some of the challenges that we might face or we are facing in our, other African countries. And there was weak coordination among different task forces at the beginning. So in an ideal world, an emergency response is a litmus paper for countries, national health system. It should be like a switch for our office light. When the emergency starts, we click and every room, starts to give light. All the lamps in every room pops up. That should be like the ideal resource mobilization, emergency response all over the country. So that there was a weak coordination. So it affected our resource mobilization as well. Shortage of readily available resources is another challenge. So far, from all those donors who have committed, they took time, for repurposing some of them and also to get donor grants. So we have to move fast. Lucky enough, the epidemics didn't really took over all our attention. So at least, it's giving us time for preparation, but that is another challenge. Inexperienced private sector, since we haven't really invested on private sector for health response, even though we have started even using the GFF, grant, but it was not really, matured enough. So that inexperience for local production capacity, we have learned a lesson, and that is an area of improvement which we need to strengthen. And high cost of commodities, I'm sure everybody felt this problem as a challenge. Next one, please. Maybe the last one. Summary takeaways. I will go fast in 30 seconds. Emergency preparedness and response plan is really critical for any resource mobilization and allocation. It's rate limiting. It has to be done with good assumption and logic. Second one is there should be a consensus or basic assumption for scenario computation. In the first meeting where we called all partners to show them that was like $500 million preparedness plan, everybody said, oh my God, this is humongous. We can't fund this. And they wanted to see the scenario. They wanted to see the assumption. So we have adjusted afterwards. So consensus has to be there. Even the local government, to allocate more money, they need to have a basic understanding of the assumptions and the scenarios. The third one is monitor and communicate resources mobilized using a dashboard. That is very, very critical. People wanted to see where is the gap, how much has been allocated, how much has been used, and how much should also be generated. And they ask us also priorities. So that is very critical. Identifying the existing resource, in addition to waiting for new resource, is another one, so for repurposing. And the fifth one is opportunity for domestic resource mobilization. I can tell you confidently that the government more than ever has seen the impact of the health sector on the overall economy. So we use this as an opportunity for domestic resource mobilization for health service strengthening. All the equipments, all the facility refurbishments, all the human resource recruitments, these are a long-term investment which we have used for using domestic resource mobilization. So all of us need to really use this COVID for long-term health service strengthening investment. The role of private sector, as I said, is critical. And we have learned a lesson, even though in an emergency, that we need to not only just give free, resource, but also improve their capacity. And also technology transfer and entrepreneurship is a critical area which we have seen the impact greatly. And donor engagement for repurposing is also another important summary takeaway. I thank you so much.
There you go. Thank you very much. Namaste Ganalo.
Okay.
That was very, very interesting. I know many people will have really learned and listened from this experience, from hearing what is happening in Ethiopia. So I'm going to see if Sean is back on the line, because then we can maybe listen to the experience on chat. Sean, if I could please ask you, I think several of the points that you also had in your slide were made by Dr. Yeko. So if you could move to particularly the areas that have not yet been touched on, that would be very helpful so we have time for questions, because we have more than 120 people online. So if we get 120 questions, I want to make sure we have time to answer. Thank you.
Sure. No problem. Can you hear me?
Yes, we can.
Good news. Okay. So if Joy doesn't mind to put up the slides, please. Thank you very much. I appreciate it. So our team has been doing resource mapping to support implementation of National Action Plans for Health Security, or NAPS. This encompasses resource mapping for COVID-19 preparedness and response. Some highlights of our resource mapping for NAPS include the identification of $50 million in funding for plan implementation in Sierra Leone, recognition from the Deputy Prime Minister of Ethiopia of the contribution of resource mapping to the country's health security, and the resource mapping that we're able to do successfully at the subnational level in Nigeria's 36 states. Next slide, please. With resource mapping, we help the country to identify financial and technical resources to support implementation of national priority health security actions. We work with the country and partners to map the activities and investments in the country and to show where the needs and the gaps are. We also highlight areas of potential collaboration between the country and partners and bring them together to discuss collaborating for the implementation of country plans. Now, the objective of our work is to use our resource mapping data to promote dialogue between countries and partners and to establish partnerships for health security. Next slide, please. So our approach is to match the health security activities the country has prioritized for implementation with the resources that are needed for implementation. This involves looking at domestic investments, existing partner investments, and potential partner investments, and coming up with the resources for implementation of the national priority actions. Next slide, please. So for COVID-19, we will be mapping coronavirus-related investments and activities in the countries, allowing policymakers, donors, and partners to see where the gaps exist and where more investment of financial and technical resources is needed. We will be mapping and highlighting potential areas of collaboration to facilitate joint planning, coordination, and evaluation in implementing COVID-19 preparedness and response. Our goal is to foster dialogue between the country and existing and potential partners to create a strategic partnership for COVID-19 preparedness and response in the country. We'll also be tracking and monitoring the implementation of the country's plans. Next, please. We are currently working in collaboration with the DFID Tackling Deadly Diseases in Africa program to launch a pilot effort for COVID-19 resource mapping in countries including Chad, Niger, and Cote d'Ivoire. We will adapt and update our resource mapping tool for each country's COVID-19 preparedness and response plan. We will also provide trainings in use of the tool. We will coordinate and collaborate with partners, WHO country offices, and ministries for data collection on the ground, both on the national and on the subnational level. We also intend to expand the program beyond the pilot countries to support other countries in resource mapping for COVID-19 plans as well. Next slide, please. So this is the dashboard of the COVID-19 resource mapping or REMAP tool that we built for Chad. Chad's COVID-19 plan is different from other countries in that it is divided into two scenarios. One is a preparatory scenario, and one is for when there is sustained community transmission in the country. Our tool maps and monitors both scenarios, providing data and visualization of country and partner activities. The tool is based in Excel. We're also currently developing a web-based version. All the buttons in the tool are clickable and bring you to different pages within the tool. You can also click on the country map in the top left corner. Next slide, please. Clicking the country map will bring you to a page like this, showing the geographical locations of partner investments and actions related to COVID-19 in the country. There's a drop-down menu where you can select which partners' activities you're interested in seeing. For example, this slide shows the location of FAO COVID-19 related activities in the country. The user could also choose to see the activities of any other partner, such as US CDC, UNICEF, WHO, World Bank, etc. Please note that the data I'm showing here is not real, since we have not yet begun the mapping in Chad. It's being presented just to give an example of what the tool looks like. Next slide, please. The tool will show the details of each of the partner activities. Chad's COVID-19 plan, as other plans are, is based on pillars such as laboratory, case management, risk communication, and community engagement. The tool will allow users to see what partner activities are supporting which pillar. This slide, for example, shows partner activities that support point of entry in the country. Users will be able to see the specifics on each activity, including the name of the partner, the type of assistance, the pillar being supported, and the region receiving the support. Next slide, please. In addition to mapping resources, the tool can be used by countries to track implementation of their COVID-19 plans. If you look in the far left bottom corner of the dashboard, you will see a button that says Activities. Users can click on the Activities button to see all the activities in the country's COVID-19 preparedness and response plan. Next slide, please. We have loaded all the activities in the country's plan into the tool. This slide shows activities under the pillar of coordination and management of the epidemic. Next to where the orange arrow is on the slide, there's a drop-down menu where the country focal point can specify how much of each particular activity in the COVID-19 plan has been implemented, whether it be 10%, 25%, 50%, or completed. This allows countries to track the implementation of the activities in their plan. Countries can also use this data sheet to match partner investments with specific activities in the plan and to indicate whether financial or technical assistance is needed to complete each activity. A major focus that we have in our tool is technical assistance, whether it be expertise, trainings, maybe consultants providing SOPs, in addition to the financial assistance that countries need to implement their plans. Next slide, please. So data collected through the tool on the implementation of COVID-19 activities is used to create these visualizations of how much progress is being made in each of the pillars of the plan. For example, maybe 25% of the risk communication and community engagement activities have been implemented, but only 8% of the point of entry activities. This kind of visualization allows policymakers to see where problem areas exist in implementation and to take steps to address them. Next slide, please. We also tried to identify funding gaps in the country's COVID-19 preparedness and response plans. We looked at the total cost of the plan, how much the government is contributing to the COVID-19 activities, how much the partners are contributing, and compare it to the total cost of the plan to determine the funding gap. So I'll turn it back over to Ludi now to present our concluding slide.
Thank you, Sean. Next slide. So in summary, that we prepared this tool is for our mapping the COVID-19 implementation and also matching the country plans that is under the platform of COVID-19 SPRP with our what we call a strategic partnership for IHR and health security portal, of which we already mapped since sometime since 2014 in 192 countries on health security investments. This is such as Global Health Security Agenda, World Bank, Redice, Plan, Regional Health Security Australia, and so on and so forth. So in moving forward, we are ready to support GHF country in resource mapping for COVID-19, and I think a lot of unifying our effort can leverage also a better impact for the country. WHO is ready to adapt the REMAP tool to include the World Bank GAF resource mapping and country investment case. As also, we can provide a better visualizations in terms of the funding gap, consistency, as most of the coordination of COVID-19 is held by WHO in collaboration with Global Fund and others. And also discussing coordination in terms of data collection. This is something that we highly seen as an important step. Particularly linkages to the health strategies. I really appreciate the presentation earlier about the linking to the health system and health delivery. And I think we are, excited to piloting the program with the World Bank GAF collaboration. The purpose is this resource mapping of what we develop is a low cost because we realize that developing a very highly speed system, it does not work in 196 countries. So we start very simple, but it's an aggregated data going up into the web base, which is currently we are doing as well. And we provide training. Normally the resource mapping, it takes 3 days, but it's also continuing process in the context of IHR and health security. As we are also have another monitoring in terms of implementation of international health regulation, of which each country should increase their capacity to prevent, detect, and response. With that note, I thank you for this opportunity. Petra?
Thank you very much, Dr. Ludi and Sean. That was very, very helpful to put all this together. I'm going to ask Joy to please put up the slide with our email addresses because we would like to allow some time for question and answer. I saw that there are more than 120 people online, so I'm sure there will be questions. Please email your question if you're an English speaker to myself, and my email address is up there. If your question is in French, please email it to Joy, whose email address is also up here. And we would appreciate if in the email you can specify your name, the position you're in, and the organization you work with, and the country, so that we can put the question in context. So do not send questions and comments in the messaging section of this of Kudo, because it goes so fast that we could not keep up with the questions. So please let your questions come in, and then we will start answering them. I already received the first question. So as soon as I get more than one, we will start answering. Thank you. I have the first two questions in, and given that the time is not very long, I'm going to suggest that we start with those first questions already. The first question is about the support for the resource mapping and the expenditure tracking. And I think both WHO and GFF alluded to it, but the question is, what support does the GFF provide, and what other sources of financial support are available for doing this? And then the next question is, for both WHO and Ethiopia, is there also any experience to share in terms of resources to routine healthcare services, especially RMET? Does the mapping identify gaps in those areas? And how does it look at the comprehensive aspect? And is there anything from WHO in this regard to ensure that the routine healthcare services are not disrupted? So maybe Dr. Yeko, I'll start with you, and then I'll come to either Ludi or Sean, and then I'll get to Marion.
Thank you so much, Petra. One of the task forces under the COVID response is the task force overseeing the essential and vital services, and maternal and child health is one. So what we did was, from the existing resources for this fiscal year, we maintained and also repurposed some of the critical resources we have to critical services such as maternal and child health. So for instance, we have a pool fund called SDG Pool Fund, supported by 12 donors. So what we did for essential services, we maintained all the fiscal year budget. We didn't take it to COVID. So critical shortage on vaccines, on family planning commodities, on skilled and delivery equipments. This we have already repurposed our pool fund to the essential services. That is one. And the second one is we developed a guideline how to maintain essential and vital services while providing services for COVID. So human resource, rooms, equipments, infrastructure, they all maintained and separated from COVID care at a facility level. But one challenge that we faced and we're trying to sort out is to provide essential services during the time of such an outbreak. The providers, they need personal protective equipment. So when we procure anything for COVID, for essential services, we also include them in the distribution. So the personal protective equipment such as medical masks, all the equipments we buy for COVID, it also is used for essential services. That's what I can say.
Thank you very much, Dr. Yeko. Dr. Ludi or Sean?
Thank you, Petra. So our process is definitely very focusing on the current COVID-19. So this is very important. And then one of the key important pillars under the COVID response plan is ensuring all the essential services we're running smoothly. Now, in the context of implementation is different country by country. When we talk about essential services, one country, there is no uniform. In other words, is that our resource mapping is a tailor-made basically to the country. And then addressing to the hotspot of where is the most affected region. So this is very important, the movement of people, the affected region, but it's also to allow that which affected hotspot in terms of COVID, but it's also hotspot for essential services. So where is the vulnerable population and risk? So this process, is being considered. We have a lengthy discussion, of course, with our primary healthcare sectors group within WHO, UHC partnership group, about access to the medical. What we are trying to achieve through the resource mapping process is to have this efficiency. For instance, as you know, that many plans that the government is already proposing for, let's say, Ebola plan, preparedness, you have measles plan, you have influenza plan, and now you have COVID plan. So one of the criteria with the resource mapping is to integrate those specific plan into health security plan. If the country is already having a emergency operations center, let's say in one area, that center has to run for a long-term capacity in the future and blend it into health system. Essential health services will then also create a pillar for sustainability process, what we call it, when we are dealing with the future recovery and the future, aftermath of the COVID in terms of sustainability. So in other words, yes, for the COVID, but it is depending on country by country. There is no uniform one size for all because it's very different structure.
Then I'm going to move to Marion. And Marion, I'm adding a question for you that also just came in. That's asking, what is the role of the liaison officer with regards to the resource mapping and expenditure tracking in the context of COVID-19? So in addition to what I already asked, thank you.
Sure. Thank you, Petra. So what support can the GFF provide with respect to resource mapping and expenditure tracking of COVID response? So I think I would say, first of all, we provide support, we support ministries of health in conducting their resource mapping and expenditure tracking of either their investment case or national health strategy. And I think as part of this exercise, so, we have 2-3 people supporting that endeavor. As part of this exercise, those people as well, the same people working side by side with the ministries of health, could support a resource mapping exercise of COVID-19. I see economy of scales here. Obviously, if, the work is too much, we could provide additional resource to hire a short-term consultant and to actually make the team stronger. Make the resource mapping expenditure tracking team supporting the ministries of health with the investment case resource mapping, but as well with the COVID-19 resource mapping. So that's kind of the first part of the answer to this question. The second part, in terms of what type of tool they could use, I think those countries, those GFF countries, which are using the GFF resource mapping for investment case, for national health strategy, could easily adapt that tool to the pillar of the COVID-19 plan. But I would say it's really up to the country, what the ministries of health, wants to use. If they want to use the GFF resource mapping tool to do the resource mapping of the COVID-19 response plan, fine. If they prefer to use WHO tool, fine as well. I think it's really, it's a country-led approach. So it's really up to the country, the ministries of health, to see what they can do. And we are more than happy to facilitate the connection, with LUDI's and Sean teams to make that happen. And right now, actually, we are in touch, with LUDI and Sean to see how to coordinate the resource mapping of the COVID-19 response plan with the overall resource mapping of the investment case, like in Niger and Côte d'Ivoire, we started some discussion. So the second question, Petra, so the role of the liaison officer. So I think, it's first of all to let us know if there is any specific demand on how to support countries with the resource mapping of COVID-19. That's a little bit how it started in some countries. GFF liaison officer wrote us an email and say, hey, here there is a demand from the ministries of health to support with the resource mapping of COVID-19. So I would say maybe, just remain as usual in touch with the policymaker, with the ministries of health. And I know most of our GFF liaison officers are involved with the COVID-19 response. And, just let us know if there is any demand. And then we can coordinate as well with LUDI. to see, how we can maybe divide the task, because there are maybe some countries where we are more present and some other countries where Ludi has already started engaging. So I think it helps, to get some feedback from our dear GFF liaison officers on what's happening in the field on the resource mapping of COVID-19. And of course, happy, if they want even to be involved with the data collection. I think it's super helpful as well. Over.
Thank you, Marianne, and I can especially imagine the whole connection with maintaining the essential services is important, and looking at that resource mapping that has happened in several countries with the GFF support. And I think also last week, both on the 2 weeks ago on the supply chain webinar and the webinar before that on health services, we'll probably see some changing demands as well and changing strategies on how to maintain essential services. So taking that into account, into re-looking at the priorities and the resources needed if you're going to outsource to private sector or you're going to have a different strategy to provide essential services. That will also need to be taken into account, I imagine.
Petra, may I just add something to what you've just said? Because I realize it's a very important point, you brought, and this is as well something, we got in touch with, the resource mapping expenditure tracking team of the overall investment case national strategy. Regardless of whether it's a resource mapping of COVID-19 or the national strategy, I think at this time, it's very important to have some financial data backing up whether there is deprioritization or no of essential health services, because this is what we hear, but we don't really know whether this is happening. So the only way to know whether this is happening or not is to have budget data showing that some donors, but as well the government has been, shifting some money from essential services to COVID-19, and for good reason as well. But it's important to monitor that. So we are actually encouraging GFF resource mapping team to capture this information, either as part of the resource mapping of the investment case of the COVID-19 response. And this is as well something that Ludi touched upon and what they are capturing as well in the WHO tool, which is really great, I think. Over.
Thank you, Marianne. I'm glad you made that point because I think it's very important. So there's some questions here from Nigeria. A colleague at the EU is wondering, is the resource mapping open source? And also, he's highlighting that there are partners like UNDP and DPG Health that are already carrying also out certain resource mapping. How will the GFF and other efforts be linked to these, or what's the added value? How do we make sure that this is all aligned? And how do you minimize impact of double counting when the donor and the implementing partner are in the same resource mapping exercise? And then the last question is, what's the mechanism of decision making for allocative efficiency of your pool or basket funds? Is it by the board, by consensus, or by decision? I'm assuming this question is particularly for Dr. Yeko. So Dr. Yeko, I'll start with you, if that's okay.
Sorry, Petra, can you say it again, the last part?
Yeah, so the question is related to the mechanism of decision making for your pool or your basket fund, the SDG fund. Is it by consensus, or who decides? How is it decided what the funding is on? And the other question is related to other resource mapping that may happen in the country. I don't know if in Ethiopia there's any other resource mapping happening. And how do you ensure there's no double counting when the donor and the implementing partner are both providing information? And I know you have two other colleagues. If you want any of them to respond, also please let us know and we get them to join.
I can respond for both questions. So the SDG pool fund, they have chair and co-chair and regular meetings. We have a joint financial agreement signed between us and also our Minister of Finance. So all decisions are made based on, agreements. They have within their own meeting, they can decide, and then the agreement says it has to be agreed by both parties. So the good thing about the SDG pool fund is it follows our comprehensive fiscal plan for a year. So once during the preparation of the comprehensive plan, which follows the National Health Strategic Plan, they follow this plan. So out of the 5-year National Health Strategic Plan, we draw an annual comprehensive plan. So they will take part in preparation, and when it is final, they will endorse it, what is going to be funded through the pool fund. One critical component to it is the SDG pool fund grant is a gap filler. It's not the first resource that we are going to put everything. So the first commitment from the Treasury, the second one and from other sources like Channel 1 and Channel 3, during our resource mapping, we include them. And the last gap analysis done, and which is going to be filled by the SDG pool fund. We use this, and we have a coordination platforms for a technical, conversation and meeting. We have a joint consultative committee meeting, and for the final decisions, we use a joint consultative forum where the minister chair and major plans, major priorities will be set, agreement done, and then the pool fund is managed accordingly. And every quarter, we provide resource utilized progress of activities as a triggering point. And it has a component of disbursement linked indicators or performance-based financing. Part of it is performance-based financing, which is funded by World Bank, GFF as well, but there are other partners which we call it trigger-based funding. When we submit a report, when we submit a plan, when we do joint supervision, those are the trigger points. And part of it is for performance-based funding. That's how it is managed. So a resource mapping, as I said, we have one plan, which is our investment case for GFF, for instance, the National Health Strategic Plan. So for that plan, there is a resource mapping exercise, which was, under the process. But now this COVID came in, we have used almost similar exercise. We mapped where the resources are. Then we use this dashboard, to monitor our progress. But everything is going to be integrated, and it's going to go into one tool, which is our Minister of Health account. That is my response.
Thank you very much, Dr. Yeko. I will ask Ludi and or Sean on the resource mapping, whether it's open source, and
Sure.
how to work with other resource mapping and the double counting question, please.
Thank you, Petra. So just let me, first of all, I will answer, and then let also Sean, if he would like to add. Let me explain a little bit about our tool. Our tool, before the COVID-19, we have a process that what we call it the International Health Regulation annual reporting. Every year, every member state legally binding has to report their capacity to prevent, detect, and response. And this is where, as the evidence, no one can prepare with the COVID as a result, because it's out of unknown disease. But the next process, systematically, rather than a self-assessment by the country, we have what we call a joint external evaluations process, which is assessment with with peers, other countries, invited to look at not only just looking at on papers, but visiting the field in terms of laboratory, in terms of health system, in terms of health workforce, and this is comprising of 19 technical areas. This is the process that we have done. Once they have done that, they develop a national plan, which is, in principle, is leading by Minister of Health, but is supported by different ministry. What resource mapping does is really putting back into a concretizing from what they plan into what exactly, who's doing what, where, what existing program budget, and also activities or project with partners. So since health security in terms of cross-sectoral is much more broader than health system, it is a very complex. If you can see that, within health security, there is military involved because you have biodefense activity. You have a laboratory over there. You have an isolation system for the troops, not for public, for the troops. So given that and so much enriched in terms of multi-sectorality of health security, therefore our exercise usually take a week and in the context of workshop. This is prior of COVID. And usually we brought in some, depending on the country by country, but in the size of 10 to 12 ministries, including agencies, including national public health institutions, including non-governmental organization and donor existing at the country level. And here we develop what we call it the multi-sectoral preparedness committee, which is looking at where is the key issues. As also my team is doing a lot of collaboration with the parliamentarian, we engage with the financing committee of the parliament and House Speaker. So our experience when we did it in one country, we realized that Ministry of Defense is building a laboratory for the Ministry of Defense, where is funded and built by China, and then a lot of and then Ministry of Health by US, and for the first time in the country after 2 years implementation, they didn't know that both is built the same laboratory. They didn't have the connections. So what resource mapping tool is, I have to say during the exercise is a very intense exercise because a lot of mandate, a lot of issue, a lot of duplication of mandate, territory between ministries. But WHO here is together with partners in the country, build that into a consensus building. And then at the end of the resource exercise, we speak with the higher level, Prime Minister office usually, and then we address key issues. I give you examples. Sometimes implementation of the World Bank is getting stuck. We talk with the policymaker and where is the bottleneck. So what WHO is convening power, bringing the value on what health security standard, and also expanding to other partners, existing partners like Global Health Security Agenda, or the European, ACP in 79 countries. We are currently using the resource mapping. The TCAT, they're using the resource mapping. The G20 or initiative by the Russian to the Central Asian country is basically also using our tool. In short, is that what our tool is not necessarily open for public because it belongs to the government. But we visualizing in the public in the different manner in terms of traffic lights, because numbers is always an issues with some donors in particular to put it in terms of numbers. Although we still in the discussion with some key partners to engage further, because one is very transparent, the other one is cannot by law they cannot share that number information. And health security, a lot of US in terms of investment they made. So we put the traffic lights in millions green, and then we do have the actual data. And then in terms of another tool that is important, we have a portal. This portal we feed all the information from the resource mapping into the portal that we visualize for public. So this is publicly available. And then we have what we call it the matchmaking tools between partners to countries in the context of health security preparedness, where we already have validated information from 85 partners in 192 countries in terms of what is their priorities. So we match the donor priorities with the country needs and gaps. And then here because we map into district to district, we also looking at and stimulates the conversation of ownership. In other words, is that the discussion is not stopping just mapping, but finding a solution in terms of how country can take over in the long run in terms of ownerships. Because that's the goal that we are looking at, because is to make sure that they invest better, they have had workforce that is ready, they have an essential infrastructures that is needed.
Thank you, Ludi. I think that's very helpful. I have a lot more questions, so I'm going to ask everyone to be very succinct in their response so that we can answer as many questions as possible. So I'm just going to ask Marion. There's quite a few questions about two things. One is it possible for WHO and GFF to work together to harmonize and share with countries? Because a lot of countries a lot of people highlight that they see the COVID-19 is very important and it's very impressive with the dashboard and so on, but also the need to look at the allocation of funding to essential services and making sure that those funds are not being redirected. So, for example, the program in Chad, Niger, or Cote d'Ivoire, if funding is not taken into account of what is allocated to essential services, then maybe funds may be redirected to COVID-19 response, and that would be really, really not a good thing. So could you talk about that, Marion or Vibhuti, and also a specific question related to this from Rwanda, which has a fully functional resource tracking tool system that has been running for over 9 years. And they want to know, can we integrate specific COVID-19 related data structure? And what is the best strategy to collect data and inform coordination efforts in real time? Is a question again from somebody else.
Petra, Marion, is it okay if I go first and quickly answer the question on Rwanda and Nigeria, and then Marion, you can take over the harmonization question?
Go ahead.
So on the question on Nigeria, Petra, that was asked in terms of existing resource mapping, what we try to do, and we are doing this in Nigeria right now, is carefully doing a landscape analysis to see what resource mapping has been done with which partner and in which states in Nigeria, because that's a big challenge. Not all states are always covered. Some resource mapping only focuses on immunization. Other resource mapping we know has looked at HIV, TB, malaria. So we do a very careful analysis to make sure that there is no repetition in terms of effort. And whatever information has already been captured, for instance, in the latest NHA, we adopt that information instead of trying to gather it again. So that's one question. The second question on duplication between donors and implementing partners, there isn't, unfortunately, a easy fix. The only thing that you can do is go through it line by line and make sure that the information that the donor has provided, say UNICEF, and the information that the implementing partner has provided matches up, and that it is not counted twice. So we go through a very rigorous data validation process. And then the question on Rwanda, yes, Rwanda has a very extensive HRTT, which is their resource tracking tool. This is a longer answer. So what I will request, Petra, is if I can get the contact information of the person who asked it, and then Marion and or I can follow up with them separately, because that will require a much longer response. Over.
Sure. And Petra, can I build on what Vibhuti has said? Hello? Okay. Can you hear me, Petra?
Yes, we can hear you well. Go ahead, Marion.
I'm sorry. Yeah, so no, great questions. And one thing as well I wanted to mention is that the GFF resource mapping tool is obviously open source, and usually we kind of provide a model, but again, this is a country-led approach, so the ministries of health, fine-tune it with support from some local consultant that we hire for this purpose. So I just wanted to mention that. So great question on the WHO GFF harmonization. I think it's a fantastic question, because we know at ministries of health level, the capacity is not necessarily very high. And even if it's high, they are extremely busy. So let's, donor not make their work more complicated as it is. So we are actually started discussing, with Ludi's team to see to which extent we can harmonize, the WHO and the GFF tool. And that's what I was referring to a little bit earlier. So, for example, in Côte d'Ivoire, there is the resource mapping of the investment case and a national health strategy that we are supporting. And so Ludi's team is supporting the resource mapping of the COVID-19 response plan. And so they are quite strong with the data visualization. I think we might have an added value with, the data collection. So we are thinking, maybe not tomorrow, but I would say on the long term, on maybe next year, to see to which extent we can harmonize the data collection tool, both for COVID and for the overall national strategy and investment case, and bring that together with the same visualization. So this is really something which is on the table, and it's now discussing how this can happen at country level, because each country has some specificities. So we will see how it goes, in a specific country like Côte d'Ivoire, maybe Chad, and then we can report back. But overall, we very much agree with that comment. On Rwanda, as Vibhuti said, I think this is a longer discussion, but I would say in a country where there is already a strong institutionalized resource mapping exercise, where the Ministries of Health is really taking the lead and, gathering all the different financial budget data from donors, from the government, as well as expenditure, I don't think this is very difficult, in such a tool to add a column for, COVID-19 and then break this down by priority. I would really encourage countries who already have an existing functioning resource mapping tool to build on that tool and to include those COVID-19 categories. And I would assume as well that, there will be in those investment case or those national strategy a strong component related to health security within which COVID-19 would fit well. So, in those countries where they have a strong resource mapping, an institutionalized resource mapping tool, I think there is an opportunity to really anchor that component in the tool, in the existing resource mapping tool. In other countries, which are just starting with the resource mapping of the investment case, national health strategy, or even have not started yet, I think the WHO tool is really a great opportunity for instance, to start from. Over.
Well, thanks, Sean from WHO. Just want to echo what Marian is saying, that I think there's a great opportunity for us to work together, and it's a very good question. In fact, right now, I and my colleague Bismarck in Ghana are working on integrating the World Bank GFF mapping for investment cases into our REMAP tool, and we're hoping to have a draft of that ready within the next day or two to share with Marianne for feedback. As we're about to launch our resource mapping efforts for COVID-19 in Chad, in Côte d'Ivoire, and in Niger, just as a beginning, I think that there's great opportunities for our teams and the World Bank GFF teams to work closely together to harmonize and support one another, and to make sure and give countries one tool to work with. And as the questioner pointed out, these things are related. If you're talking about health systems and you're talking about health security and you're talking about them siloed, it doesn't make sense. So if you put them together so people can see where the funds go, then that is the best way to go. Over.
Thank you, Sean. That's very helpful. I think that if that is something good coming out of this crisis, then I think I'll be very happy, because I think it will help a lot of countries, because redirecting of funding is always a challenge in these type of situations. So there is 2 more questions related to also how to better use existing funding. So there's this point being made that Africa especially seems to have an opportunity to take advantage of the delay in the progress of the outbreak so far, and to maybe seize this opportunity to really think critically and act to make sure that aside from looking for active resource mobilization and mapping for additional resources, to really look at what they have currently planned and budgeted for the current fiscal year before COVID-19 came about, and to think about reprioritizing which activities will be mapped and included into their annual plan. And the question is whether WHO supports countries to include this in their approach and to help the MOH map what they've initially planned for the year is being prioritized and mapped back to the COVID-19 response. And similarly, there's a question in regards to the coordination mechanisms. What coordination mechanisms are available to avoid duplication in the context of COVID-19, but also looking at allocative efficiency, so also in view of the essential services. And then I think the other question that I would like to pose with this is from civil society, in also saying what can be the role for civil society in the resource mapping, monitoring, and expenditure tracking. Do they play a role in, say, Ethiopia or other countries? And would it be possible for CSOs to have a training on the dashboard that has been developed by WHO? And I guess the same question goes for the GFF too. So I don't know who wants to respond first.
WHO, I can go ahead and respond. In terms of training CSOs, we would be happy to do it anytime. And we can do it's difficult, obviously, to travel and do a training nowadays, but we would be happy to do a virtual training and just let us know. No problem. And in terms of working on the mapping with the MOH, one thing that we take a lot of care in our tools to be very flexible and to respond to the country needs. And if whatever kind of mapping the MOH wishes us to do in the country, we can adapt the tool for this. And we also, another aspect of our COVID-19 resource mapping is that we use it to inform the COVID-19 Partners Platform at WHO. Basically, the data that we do country by country platform. Over.
Yeah, and maybe I can build on what Sean has said. I think indeed, the role of CSO is quite important. As you know, as part of the GFF platform, CSO is involved. So they are involved, with the process of the resource mapping, at least, sharing with them the result of the resource mapping of the investment case. For example, in Madagascar, it's a CSO, agency, which is going to lead the data collection of the resource mapping of the investment case and the national health strategy. So the role of the CSO is of course important because, if, for example, they can really, they're in a good position. For example, if some specific decentralized level or regions don't get the money, they're expecting money, commitment from donors or from government. While the needs are high, they can really, they are, I would say, the best stakeholders, to flag this to policymakers. So I think it's quite important that they are involved. I think Dr. Yeko maybe can add more on the role of CSO in the resource mapping of COVID-19 in Ethiopia. There was some questions relating to how to better use funding available to address COVID-19. And about the planning aspect. I have to say from what I see in a few countries, and so it's maybe related to only some specific countries, but I think that the resource mapping of the COVID-19, because COVID-19 is an emergency, the resource mapping had to be done very fast. Like in 2-3 weeks, the ministries of health had to have an idea where are the funding gaps, which priorities, which region. And I think overall, this was really an eye-opener for the ministries of health to understand that beyond COVID-19, it's really important to conduct on a routine basis the resource mapping, of the national health strategy, so that the same type of questions around allocative efficiency, making sure we can address the funding gap, are addressed, when they prepare the national health strategy and they prepare their budget. So to me, it's kind of a positive externality of the COVID-19, and it seems it might have contributed really to strengthen the planning skills of ministries of health. But I'm sure Dr. Yeko can maybe add something on this. And I think the resource mapping was definitely, of COVID-19 as well, was a realization that when ministries of health started doing that, they had very little behind budget line related to health security. I remember DRC, they only had from the government 4 million allocated to health security. So what to do, with 4 million in a country like DRC to, address COVID-19? So again, I think it has really helped and maybe has been an eye opener to really take this resource mapping seriously, because it's really a tool, to better plan in the entire health sector. Over.
Thank you, Marion. Dr. Yeko, before you come in, there's one specific question for you as well that maybe I'll add so you can respond to that. It sounds, firstly, very impressive preparedness and involvement of most stakeholders. That's coming from Uganda. And the question is, you also refer to involvement of the private sector and that they're heavily engaged in the production of PPEs. And were these factories already manufacturing PPEs before COVID, or were they started during this pandemic? And is the country producing any surplus for export to neighboring countries who are currently having shortages? So while it is more about supplies, I think it's an important question that I just wanted to add, if you wouldn't mind reflecting.
Thank you so much, Petra. I think Marion has touched most of the points for Ethiopia. So existing funding, what we did was, as soon as we heard COVID, pandemic hits most, countries, we just did resource utilization for the existing fiscal year by different directorates at ministry level, and we have identified program areas and activities which haven't, spent much during half of the fiscal year, and we prepare them for reallocation. So we do that exercise usually half of the year, and then by the 9th-month performance, and we did that just before, as soon as we start preparedness for COVID, and we propose repurposing of this funding with our pool fund partners and other partners. Second one is so far we have mobilized nearly $40 million from the government. So this is also another thing that we need to, with strong plan and resource mapping, presented to the head of state who is heading multi-sectoral response by the health minister. Then such response are really rapid and then effective. So I can say within our pocket, if we show them that this is how much we have repurposed and this is our gap, then the government is also very happy to feel to add more money. Coordination mechanism, as I mentioned it in the presentation, we have started engaging all partners before we report a single case during the preparedness period. And every week we have a platform facilitated by the HPN, the Health Population and Nutrition Partners, co-chairs, WHO and USAID, where all donors convene in a Zoom meeting to present our dashboard, different question and answer session, present them our priority areas, so that this coordination mechanism. Before COVID, there were coordination mechanisms, as I mentioned, joint consultative committee meeting, as well as joint consultative forum with all our donors. And this one has been intensified during COVID on a weekly basis, sharing the information, including resource mobilization and allocation dashboard. The role of civil society, I don't have from Marion. So in the already existing
it looks like Dr. Yeko got disconnected. I'm just going to go to the last question and see if maybe we can get him to come back. I'm also aware it is time, but there is a question from the Ministry of Economy and Finance and Development from Burkina Faso. In the context of COVID-19, what procedures are used to allocate financial resources in a way that respects good governance? And there, given that the country has 13 regions and local response plans are being prepared, how can these plans be financed, particularly in the context of a pre-existing financing gap? And then maybe lastly, I mean, this is a comment on Nigeria, that indeed there's an ongoing discussion about harmonizing the Armet with an existing platform being the National Health Accounts platform. Just reiterating this point, it's not just about the mapping, but also making sure we're prioritizing based on available resources, because there will be finite resources, both for essential services and COVID-19. So just planning and thinking that the money is going to come is probably not always the reality. So somewhere I think looking at what the expenditure is important from accountability perspective, but also thinking through what are you going to prioritize is a very critical area, because the resources will not be finite. So maybe Ludi or Sean, if you want to comment on any of this, and then I'll give Marion and Vibuti the last word if Dr. Yeko is not able to reconnect.
Thank you, Petra. So what, can you just repeat very quickly about what the the question for WHO? Because
so any advice on, for Burkina, procedures used to allocate financial resources in a way that respects good governance in the context of COVID-19, and given that they have local response plans with 13 regions, and these plans need to be financed, and how to do this in the context of a pre-existing financing gap.
Right. So for the COVID-19, we do have a process, and we do have a platform, partners platform for COVID-19 specifically, of which we are encouraging countries to develop a plan, and then to indicate also what is their immediate gaps and needs. As you know, as we have a process in terms of a key focal point that being appointed to cover different region. And usually what we have is that we have a regular video conference with this country and discussing their plans. And together with the other partners and donors, we then engage with their immediate requests in terms of medical supplies, or immediate supply, in terms of, immediate needs on, shipment of ventilators and so on and so forth. So those are very operations process that is, we are already have the partners platform, and we can provide you after the call with more information about that, as well as the focal point to assist Burkina Faso further. So that is the process. The other process that is going also, ensuring the leveraging all the investment made at the COVID-19 will lead towards long-term sustainability preparedness. And that is the process that is, we are also in the parallel, but is complementary to ensure that if the current plan is, as I said, requesting for an establishment of emergency operation center, that center should then run in the future as the mechanic for preparedness beyond COVID. So it's not only just for COVID, but it's also for other essential services, as you mentioned, and embedded into the health system so that its sustainability can be maintained. So that is the allocations. We are, we have a very transparent manner in terms of matching that, what the country needs, how much they need, in kind or financial. Those are, separate group that currently is working on, but it is linked to this resource mapping. Let's put it that way. So there are different that we can, ways to support countries. Be aware also that we are working also towards our regional office, AFRO. So the AFRO can also immediately assist in terms of how they can have, if they have immediate requirement on resources in the specific region. Over.
Thank you.
Add that if Burkina wants the link to our partners platform, we can send it to them and they can immediately put in their needs and gaps, and we can get immediate attention to that. Over.
Thank you, Sean. So maybe you can share that with us and we'll ensure it gets through our focal point to the person. Marion, final words?
Sure. No, I mean, to try to provide as well some answers. I mean, I think Lodi said it very well. I mean, I guess there are several criteria which lead to resource allocation patterns to regions. But in the context of COVID, I would say first to look at the size of the funding gap, for some regions which have the highest funding gaps and as well have the highest needs, maybe the highest number of COVID cases per capita. Well, that should drive maybe, the kind of higher allocation to this specific region. I would say that this allocation should be as well kind of coordinated with the overall, funding gap analysis, which has just been done by the Ministries of Health with support from Chai, which looked at, I think, the funding gap of the investment case. So, there might be some regions where there are both funding gap for COVID, but as well for maternal and child health. And filling out the COVID-19 funding gap is one thing, but you just want to make sure that in this particular region, there are not more deaths, caused by actually maternal and child health related disease. So I think this should be really coordinated, to make sure again that there is no deprioritization of essential health services. So again, to coordinate this funding gap exercise of COVID-19 in the broader context of the funding gap of essential health services or the national health strategy, because usually essential health services like maternal, child health, infectious, disease related services are really the stepping stone to get to universal health coverage. So you want to make sure that those funding gaps as well are addressed and not only COVID-19. Otherwise, there will be consequences on the entire health system at country level. Over.
Thank you. I am really sorry. It's 9:10. So I'm going to ask for all of you on this webinar. We're doing another session tomorrow that we do a little bit less on the slides, so we have more time to answer the questions. Because I know, unfortunately, a lot of people had to drop off because they have other meetings. But I know it was very, very, very helpful. I saw lots of responses come in saying, this is so interesting, this is really helpful, it's so good to see. I think what you also both alluded to, Dr. Lodi and Marion from both WHO and GFF side, it is the country that's in the lead. So I also would definitely urge countries to ask, to make sure that this is all becoming one comprehensive thing in your country, if that's something you are interested in, because there is clearly a desire from actors to work together to make this easier. And hopefully this can be a good thing coming out of this bad situation. And I also would like to suggest to really look at, given that there is some time, at least in Africa, or not much time, to really take this opportunity to look at how to reprioritize some financing to maintain essential health services, while at the same time looking at COVID-19 response. I would like to thank you all very much. Thanks, Dr. Lodi and Sean, and thanks, Dr. Yeko. I hope maybe you are connected and can hear us. Thanks, Marion and Vibhuti, very, very clear. And you will be hearing from us again. In 2 weeks' time, there will be another session. We're just finalizing which priority topic we will address. So please stay tuned. Your liaison officer will reach out with the information. Thank you very much, everybody. Bye-bye.
Thank you. Bye.
Thank you.
Thank you. Bye-bye.